TXA. The most common side effects that we see would be GI upset, nausea, vomiting, diarrhea. Hypotension has been seen. Usually that's in the context of a bolus being given too quickly. That's why most of the time when we give a TXA bolus in trauma, it's recommended that it's run over 10 minutes. Sometimes there have been there's a concern for visual disturbances, particularly in color vision. Most of that comes out of animal studies done in rats and cats, and there's changes seen to the retina. There's not great evidence that this is actually panned out in any human studies. Obviously, a concern by TXA's action for thromboembolic events. Again, there's been a lot of literature, and there's still not a clear causal effect that's been well demonstrated. The last side effect is lowered seizure threshold, and this is reported at much higher doses. So this evidence comes from mostly the cardiac surgery literature, and these doses are 2 to 10-fold higher than those used in CRASH 2. Again, going into animal models, TXA applied to the CNS directly can induce seizures, and the thought is that it binds to the GABA receptor to TXA. Is discovered use bleeding sort of during elective surgeries. And so a systematic review of RCTs looking at these agents in surgical patients, there were 211 RCTs, there were more than 20,000 patients. TXA reduced the risk of blood transfusion by a relative 39%, requiring less transfused blood, a trend towards reducing the need for reoperation. And in that cohort, there was no evidence for an increased risk of thrombotic events, which I think overall is reassuring. So TXA was listed as a WHO essential medicine in 2011 in response to the CRASH 2 trial, which we'll be discussing. So first off, and probably the most relevant application for most of us, would be TXA in the context of... So just going to take a moment. I asked you briefly before, but who is currently using TXA regularly in their trauma patients? So a good portion. Okay. And running away again. So unless you've been living under a rock, you've probably heard of the CRASH 2 trial. So huge study, large, randomized, double-blinded, placebo-controlled, multi-center trial done by the CRASH 2 investigators out of the London School of Hygiene and Medicine. So they looked at patients from 274 hospitals across 40 countries, looked at 20,000 patients that were at risk of or had significant bleeding after trauma. And I think what's really interesting about CRASH, given that it's a pragmatic study, so basically the inclusion criteria, if patients came in after trauma and there was a clear indication or clear contraindication, they said do not randomize. So it was for that group of clinician was unsure whether TXA would be beneficial. That's how you got into this study. So patients were randomized and treated within 8 hours of injury. The intervention was 1 gram of TXA over 10 minutes, and then an infusion of 1 gram over 8 hours. The primary outcome was death in hospital within 4 weeks of injury, and then secondary outcomes, they looked at vaso-occlusive events, transfusions, as well as surgical interventions. There's a few important things to note about the study, especially when we're comparing it to later studies and thinking about how it may apply to some of the patients that we're seeing. So 2/3 of these patients experienced blunt trauma. 84% in this study were male. 2/3 had a systolic blood pressure greater than 90, and 2/3 had a GCS of 13 to 15. So this is going to be starkly contrasted in MATTERS, which is the next trial that I'll be discussing, where patients were much sicker. Only half of the patients in CRASH received a blood transfusion, and that was a median of 3 units, and only 48% actually required any surgery for their injuries. Something else interesting to note is where these patients came from. So, out of all the 20,000 patients, about 5,000 patients were randomized in Africa, about 7,000 from Asia, 2,000 from Europe, Australia, and North America, 6,000 from the Caribbean, Central, and South America. Again, this is relevant, I think, in how we can generalize this to our trauma center and the patients that we see in sort of a tertiary center. So overall, the results that they found with TXA. Mortality was 14.5% in the group treated with TXA versus 7. So not bad for an intervention that's, that initial bolus is kind of $5.75, $6. Death due to bleeding was also reduced from 5.7 to 4.9%. This is an absolute risk reduction of 0.8%, representing a number needed to treat of about 125. Something else that's important, no increased deaths from other causes. So one of the big concerns is, are people that are receiving TXA and we're stopping this fibrinolytic pathway, are they clotting more? And in 20,000 patients in this subgroup, the answer that they found was no. They actually found a significantly decreased risk of MI. They thought was likely due to the fact that if you have somebody that has any sort of risk of ischemia, it's probably more stressful for them to be bleeding and hemorrhaging than it is to decrease that bleeding and treat them with the TXA. So criticism here, though, was investigated missing in terms of, I think patient important outcomes had sort of their baseline level of functioning. So that's sicker patients. All we really have to go on is blood pressure in terms of their initial. I'm sorry, I don't know why this keeps happening. In terms of their initial injury, but if you look, you can see that for patients that had a systolic blood pressure less than 75 when they came in, it appears the trend is that they received sort of more benefit from TXA than their counterparts. And then I want you to note the trend for the time of injury at the top of the slide there. So briefly, you can see that patients that get TXA early do better. Patients that get TXA sort of after 3 hours, hard to say what's happening here. We'll discuss this a little bit further. So once this study came out, the investigators wanted to take a look at sort of the mechanism or the proposed mechanism of how TXA is working. Is it affecting deaths early? Is it affecting bleeding deaths? Is it affecting later deaths? And then maybe having more an effect with the anti-inflammatory properties. So for bleeding deaths, when they took a look specifically at that, the benefit is definitely. And I think we have to be careful in terms of how we interpret the overall study, because if you look up a lot in the sort of post hoc discussion of this paper, they just had a more sinister prognosis. I think, as is evidenced by the fact that they got TXA in a system that was just starting to use it. So the sense is you've got this crashing trauma patient in front of you, things are going really badly. We've heard about TXA, maybe, let's give it a try. So the conclusion from that paper was sort of maybe we need more evidence, and there were concerns, but ultimately I think that crash and matters and the data that we had was much stronger. They would need sort of a prospective look to confirm any of the results. So this is a study, hot off the press, that just came out actually last month. And so this was a study of severely injured adult patients. They had trauma scores greater than 15 that were admitted to a civilian trauma system, once again, during sort of this adoption phase of a massive transfusion protocol. Intervention was 1 gram of TXA within the first 3 hours, and then a 1 gram infusion over 8 hours. So the same as the crash. They looked at 385 patients, and 160 received TXA. 90% of the patients had blunt trauma, which I think is nice. So this is more similar, more relevant to the patients that we see every day. Patients receiving TXA still were more severely injured, allopathic, and overall TXA was not independently associated with the change in outcome for the shocked or non-shocked patients. But in multivariate analysis, TXA was independently associated with a reduction in multi-organ failure, and it was protective for adjusted all-cause mortality in shocked patients. Even though patients at baseline were sicker, they did no worse, and then in multivariate analysis, it did seem to be protective. So I think this gives us just a little bit more evidence that we should be applying this to the patients that we're seeing. So authors concluded, as part of a major hemorrhage protocol within a mature civilian system, it does appear that TXA continues to provide outcome benefits against severely injured shock patients. So TXA and trauma summary. Give TXA to patients that you see with significant trauma of injury. It improves mortality. So I would say if you're thinking that a patient might need blood, you of thinking of TXA. At LHSC, I sent Kelly Vogt an email, and she said she couldn't comment on all of the trauma docs, but at least she and Neil Perry recommend giving it within 3 hours of injury, and certainly not giving it after that because of the evidence for lack of benefit and possible harm. Neil Merritt was nice enough to give me his opinion in terms of some of the pediatric literature. So there's a paucity of pediatrics in different scenarios, more in the ORs for scoliosis, cardiac, and craniofacial literature. So before I move on, any questions about TXA and trauma? Any comments for? Do we have any of our TTLs here? Or?
Activate the trauma transfusion pathway, it's actually part of it.
Yes.
So it should be one of the first things you receive along with the first 4 units of blood.
Yeah.
So they actually just put it in. It's been there for probably 2 years now. So.
Except what I thought was interesting is there's actually no time, like there's nothing about time mentioned in terms of injury. So if somebody's coming from a peripheral hospital, then you might consider, actively thinking to not give the TXA. And again, I'm not sure. 2 years ago, honestly, the literature was a little bit different. It was actually very interesting. So Sean Doran did his journal club on Crash 2 results, and I was listening. It's on YouTube. I was listening to this, and at one point at the end of the discussion, ask everyone, like, so who has used TXA? And it was crickets. Like nobody had used it yet in trauma. Someone's saying, "Oh, I'm using it for some vaginal bleedings," but the landscape is changing, and so maybe we need some updating in some of our protocols.
When Crash 2 came out, it was amazing to me how little publicity and uptake there was given the size of the trial and the quality. Yeah. And I firmly believe it's because no one makes any money off of TXA. Like, it's so cheap. And if that quality of trial had been published with that kind of result on a drug that cost $1,000 and someone made money off of it, we would be bombarded by protocols and uptake, and like the mortality benefit shown in that trial with that number of people is astounding. Mm-hmm. And compared to some other things that we do and we spend a huge amount of resources on, it's kind of a no-brainer. Unless there's a trial that refutes it, it's a no-brainer. It's cheap, it has very few side effects, and we should be like, there should be huge uptake of this. So it's amazing that there hasn't been, and it's taken this long.
Yeah.
Do you have any experience with that in St. Thomas, kind of outside of the tertiary care center with trauma, like is tranexamic acid considered?
So when I reviewed that Crash 2 for like some talk I was giving when it first came out, and we got it onto our formulary as a result. I think that it still doesn't come to the forefront of our minds because we haven't had that much publicity for it. So I think these kinds of rounds are hugely important because it just needs to stick into our brain that this thing has huge mortality benefit as a potential. I mean, you know, the first trial on anything always looks really nice to have a second one, but have something as big as a crash too, so.
Yeah. Okay, great. All right, we'll move on, discuss TXA in a few other settings, and hopefully we'll continue some discussion at the end. So, TXA, evidence for epistaxis and oral bleeding. So most of the evidence for epistaxis and oral bleeding comes from small studies looking at patients that have hereditary hemorrhagic telangiectasia, for epistaxis literature, and then for the oral bleeding, mostly it's coming from small studies looking at patients with hemophilia undergoing dental extractions and undergoing oral surgery. So this has actually been used for years in both contexts and shown good results in terms of decreasing bleeding for the nosebleeds, decreasing the number of nosebleeds that patients are having per month, the amount of nose bleeding, good evidence in oral surgery as well. Not a whole lot of emerged department specific literature out there, but I think the inferences that we can make in terms of safety profiling for sort of the more topical applications. There's been some very small pharmacological studies done, and so for patients, they looked at about 15 patients and then measured plasma levels of tranexamic acid afterwards. 13 of 15 had plasma levels that were undetectable, and then 2 patients had very sort of low levels. My feeling looking at the data, if you compared the low levels that they had to people that had had an oral dose, I think that they were swishing and they swallowed some of their TXA. Small studies, not much to say, but overall getting the sense that that topical application should be quite safe, and has shown to be, although truly the studies haven't been big enough to look at adverse events. So here is sort of the ED epi and TXA paper. This is a randomized trial of 216 patients that presented to the emergency department with anterior epistaxis. Our little ampules or one of our vials, dunked the cotton in it, and sort of gently put in into the evidence is in hemophiliac patients that were treated with sort of a TXA mouthwash, and some studies have actually shown that TXA mouthwash is not inferior to pre-treatment with factor therapy. And if we're thinking about the cost difference there, that is huge. Again, these are small studies. Most of these studies have sort of less than 50 patients. A lot are sort of 20 to 30. But there does seem to be efficacy here. In terms of oral anticoagulants, for other oral surgeries, it let patients continue taking those anticoagulants and not having. For patients with mechanical valves, that could be really important. So I talked to dentistry, and they say they'll use really for any of their oozy patients. So they have somebody that just seems to be oozing after don't have contraindications. The way that they prescribe it is they get a 500 milligram tab, they crush it, they tell the patient to mix it with salt water, rinse for 2 minutes. Alternatively, if patient's still in office, they'll do the same thing, soak gauze in that 500 milligram sort of tablet concoction and just have them bite down and gauze and hold that. From their experience, he said usually it's quite effective. So my question for him was, what about this guy? So what about these patients that come to us, they've been assaulted, they've been punched in the face, they have isolated oral and facial trauma, and they're hanging out in hemorrhage, maybe waiting for a CT face, but they're spitting up blood, they're getting nauseous. You know, would it be reasonable to give TXA to him? So the particular doc that I had talked to didn't have any personal experience with this, but seemed to support the idea that that would be a good idea, either doing the rinse and spit, or soaking the gauze and just sort of having them gently hold it in their mouth for 10 to 20 minutes before this patient goes on to see dentistry. So something to consider. Is anyone doing this already? I know some people are. Got Mo and Drew. Yeah. I know that Samir and Davis, who aren't here, have both used epistaxis and for some oral bleeding and have had good results. Anyone else? No? Okay.
I've injected it into the pack.
Pardon me?
Like I've injected it into the pack.
Okay.
Like, so, you know, it's still kind of oozing after a pack, and then I've just squirted it into the pack. But that trial is like cotton ball soaked, right?
Yeah, it's not.
None of it was given IV either, right? It was all just topical. Is that right?
It was none was systemic.
Wasn't given systemic.
Yeah.
I think that for epistaxis, improvement on the way they did with cotton balls is to use Surgifoam. So if you use Surgifoam and you soak that in the tranexamic acid, the Surgifoam dissolves on its own. You don't have to be the schmuck who has to take the packing out 3 days later and he's cursing the guy who brought the guy back. So you know, particularly for these people who are on anticoagulants and it's horrible to take their packing out 2 or 3 days later, soaking it in Surgifoam will allow it just to dissolve on its own and you get the benefit of the tranexamic acid.
Oh, that's a great idea. So a lot of different ways that we can be using it, and something else sort of in our armamentarium. Now, the one thing about this trial, they didn't really compare it to anything else. They didn't compare it to using other agents for stopping bleeding. But again, something new to try, something to consider next in epistaxis. So this is probably my favorite slide. and I feel like after seeing this, I now have an awesome, if not slightly inappropriate and disgusting, costume planned for Halloween 2015. So Pace won best costume at our Halloween party last year, but Pace, this is it's coming. So other well-described uses of TXA include the use of TXA in menorrhagia. So there's been a number of studies done, prior to FDA approval, especially in 2009, showing that TXA significantly reduces bleeding from 34 to about 54%, so by a significant amount in women that are taking it. Most of the doses, if you look, are sort of 1 gram to 1.5 grams, 3 to 4 times a day. Across a lot of studies, it's also been shown to increase quality of life for women with menorrhagia. They have less leaking, less discomfort, they're able to function better at work, they're able to be more active in their home life. So overall, it seems to be having good effects. It is significantly more effective than intranasal desmopressin and some of the hormonal therapies, and only the IUD with levonorgestrel or Mirena reduced menstrual blood loss significantly more than so potentially a good option for women that are coming to you with heavy menstrual bleeding. Obviously, we're not going to be putting IUDs in the department, and with the hormonal oral contraceptives, I think that a lot of us are probably not going to be prescribing those from the ED, but TXA is something that I feel that we can do quite safely. It's across all these studies, no increased risk for thromboembolic disease was demonstrated, but looking quite critically at the research, again, it's underpowered to detect those rare adverse events. And for the most part, a lot of the guidelines caution the use of adding TXA to somebody that's already on the birth control pill in terms of their. So looking at the guidelines, TXA is now in sort of at least our Canadian guidelines as well as the American guidelines. So it can be used effectively to treat heavy bleeding. It's an option for the medical management of abdominal bleeding. Obviously, in the emergency department, if this is a first presentation, still probably want to refer to gynecology in terms of finding the underlying cause, if there is potentially an underlying cause for abnormal bleeding. And it's thought that TXA is most helpful for this bleeding that's cyclic and predictable. So for women that say, TXA performs best, less so for people that may of a non-cyclical nature. So TXA in postpartum hemorrhage. So based on its antifibrinolytic action, some of the evidence from sort of the heavy menstruation literature, there's been studies done looking at TXA and postpartum hemorrhage. So the WHO, their 2012 guidelines do include TXA if the uterotonics, such as oxytocin, fail. So if we look at the Canadian, if we look at the SOGC or the American guidelines, or the Royal College guidelines, those are from the UK, TXA right now is not included in any of their position papers for postpartum hemorrhage, but those guidelines were all written between 2006 and 2009. And so it'll be interesting when updated versions come out to see if that changes, just because the evidence for TXA really on a larger scale wasn't there. What should contribute to the body of evidence is the ongoing woman trial. So this is from the same group that did crash. Similar in the sense a large pragmatic randomized double-blind placebo-controlled trial of 15,000 women. And they've actually randomized 15,491 patients to date as of yesterday when I looked at their site. So we should be hearing data from this shortly. And they wanted to look at the effect of early administration of TXA on mortality, hysterectomy, and other morbidities. And they used the same dose as the crash initially. So a gram IV versus placebo, given as soon as possible after randomization, and then that could be repeated if after 30 minutes the bleeding was continued, or if it stopped and restarted within 24 hours. So TXA in the bleeding brain, potentially another use for TXA. So what I guess got the ball rolling for this was a crash to nested trial. So the intracranial bleed. The crash 2 trial that had traumatic brain injury. So the inclusion criteria was the same as crash 2, plus they had to have TBI, GCS less than 15, and a brain CT scan compatible with traumatic brain injury. So patients that ended up being included, there were 270, so not a lot out of 20,000. And all patients came from 10 hospitals in India and Colombia. So the main outcome that they looked at was intracranial hemorrhage growth measured by the CT scanner, looking at admission and then 24 to 48 hours later. 133 patients received TXA, 137 received placebo, and as a trend, patients that received TXA, they had less hemorrhage growth, they had fewer new ischemic lesions, and fewer deaths. So nothing statistically significant came out, but all the trends were positive. So overall, we have neither moderate benefits nor moderate harmful effects, but what this did was pave the way for crash 3, which I'll talk about shortly. The only other sort of recent and I think relevant to this discussion RCT looking at TXA and traumatic brain Thailand, were 240 adult patients that were randomly allocated to receive a gram of TXA over 30 minutes, followed by 1 gram over 8 hours, or matching placebo. They looked at non-penetrating traumatic brain injuries, hours of onset, and patients had to have no indication for emergency surgery. So their primary outcomes were progression of ICH on CT scan, and they defined so that you could either have new ICH or an increase in the size by greater than 25%. That was sort of the outcome that they were looking at, or an increase in pressure effect. So looking at midline shifts greater than a millimeter. As I sort of thought about this, those are great outcomes, except that they're not clinical and they're not patient-centered. Their secondary outcomes looked at in-hospital mortality, blood transfusion requirement, thromboembolic events, but it was really more looking at the bleeds on CT and this increase in pressure effect. So once again, there was a trend for benefit, but nothing that reached statistical significance. Look at the numbers that they got. So progressive ICH was in 18% of patients that received TXA, 27% that received placebo. So not statistically significant, but maybe a trend there. And no increased risk of thromboembolic events, but again, underpowered. So somebody decided maybe if we put these two trials together and combine them, we can find something that is statistically significant. And so that's what this study did. And so they found something that was significant. Progression of hemorrhage with TXA was less. And combining the two, they were able to find some significance here. What they couldn't find significance for, though, was things that we probably care more about, like in-hospital mortality and dependency. So there certainly appears to be a trend, but in terms of the evidence, we're not there yet. But we should have some more evidence soon. So CRASH 3. So these people have their fingers in a lot of pragmatic trials, looking at TXA in TBI. So this is a study looking at 10,000 TBI patients, randomized to TXA versus no TXA within 8 hours of their injury. And again, they're doing this eligibility criterion where it's the clinician's uncertainty as to whether the patient should or should not receive TXA that gets them randomized in the trial. Infusion is the standard CRASH 1 gram IV over 10 minutes, followed by the infusion of 1 gram over 8 hours. Something a little closer to home is the ROCK trial that's going on. This is a pre-hospital trial looking at TXA and TBI. Enrollment this spring. And they're going to compare 3 groups. So a gram bolus pre-hospital, and then the regular infusion while in hospital, a 2 gram bolus pre-hospital, and then saline while in hospital, and then a true control or saline and saline group. So results of these I think are expected sort of in 2017 or so. So I think that it's something for us to keep an eye out for. The evidence isn't there yet, although there is trend for some benefit. The other role that TXA is being investigated for is the use in subarachnoid hemorrhage. And as I mentioned previously, it was listed actually as a contraindication because while it seemed to it looked like it was increasing ischemic complications. So Cochrane reviewed all the available literature. There is new literature coming out that perhaps if we preventatively try and treat for ischemic complications, that and there actually may be benefit. So this review found that TXA reduced the rate of rebleeding by approximately 35%. Evidence of benefit on mortality, and couldn't show evidence of benefit sort of on overall functional status. At this point, it's not ready for prime time. Saying that, that was sort of Cochrane's conclusion. In the American Heart Association and American Stroke Association 2012 guidelines, TXA actually shows up for management of aneurysmal subarachnoid hemorrhage. And it says that for patients with an unavoidable delay in obliteration of an aneurysm and is at a significant risk of rebleeding with no compelling medical contraindications, short-term or 72-hour therapy with TXA is reasonable to reduce the risk of early aneurysm bleeding. This is never something at this point, obviously, we would be deciding in eMERGE. More something for our neurosurgical colleagues to consider. But there's about to be a lot more information. So stop OS. All these trials use one gram over 10 minutes, followed by the infusion. Is looking at TXA given within 4.5 hours of hemorrhage. TICH2 is hoping to enroll 2,000 patients by 2017, and they're at about 900 so far. And then Ultra is looking to enroll hopefully about 1,000 patients in 3 years, and that's been ongoing since 2013. So again, hopefully there'll be a little bit more information coming our way. Oh yeah, this is Drew's favorite slide. So TXA in GI bleeds. There's some evidence, it's not great evidence. So one of I think the biggest problems is that if you look at the body of studies and the group of evidence that you have for TXA in GI bleeding, only 2 studies have ever compared TXA to endoscopic therapy. Only 2 studies compare TXA to cimetidine or lansoprazole, and the most favorable study was published in 1983. And our standard of care has changed a lot since then. Patients didn't receive full endoscopic workups, and so it's hard to say what relevance TXA versus placebo has in the changing practice climate that we see today. So overall, 4.9% of patients that were randomly assigned to TXA versus 8.4% of patients in the control group died with a relative risk of 0.6. So there does appear to be a mortality benefit when they looked. This was 8 RCTs that they compiled, 1,700 patients. But when they went to confirm the analysis, and look at that patients that had missing outcome data, if they assumed worst possible outcome and treatment failure, the analysis didn't hold up, and that was no longer statistically significant. So TXA appears to have a beneficial effect on mortality, but because of the high dropout rate, risk of bias, and low quality of the previous studies, we can't really recommend it routinely. Good news is our friends that and Woman and Crash 3 also have their fingers in the ongoing HALT-IT study, looking at 8,000 adult patients that are going to be randomized to TXA or placebo in addition to each center's usual care. And so they're going to include adults with acute upper and lower GI bleeding, and again, will be included if the responsible doctor is substantially uncertain as to whether or not they should be using TXA in this patient. Patients will get a gram of IV TXA up front, and this one is a little different. They get a little bit more. They get 3 grams of TXA over the next 24 hours. So about 2,500 patients are enrolled to date. So again, keep it on your radar as something to think about. So, hopefully I've convinced you. How do you actually get this magic medication at LHSC? So, it's on Hugo. Yesterday I went to UH and tried to figure out how easy or hard it would actually be to find TXA. Ordering it seemed to be relatively easy. Finding it was a little bit harder. So, at UH at least, I can't tell you for Vic, it is not in the Pyxis in Pod C, which is where you might be dealing with your epistaxis and your oral things. There are 2 vials, actually 1 now because I have one in my purse. There are 2 vials in Pod A. And this is what our version looks like. It's a gram in 10 cc's. And this is our ED quick reference. So, hashtag tweetable moment, hashtag EM London, hashtag Drew made me, hashtag Kate Heyman. So, this can be sort of a quick reference for when and where and how I think there's good evidence to be using TXA in our day-to-day emerge practice. So think about using it. In trauma, if you think this patient is going to need blood, if you are worried about them, give them TXA. It's cheap and it saves lives. Only use it less than 3 hours. Think about using it, giving it a try for epistaxis and oral bleeding as well. I'd like to say a few final thank yous. So to Chantel, who is not here but is enjoying vacation, for all her hard work. For Drew, for putting up with my many additions to Dropbox and leading me to, I think, certainly PowerPoint superiority compared to what I started with. I read Death by PowerPoint and realized that I had managed to fall into every single trap. And thank you, Drew, for being a great reference. I'd like to thank my mom, who came out despite the fact that she does probably had no idea what I talked about. And I'd also like to note that when she came in, she brought, because she was really confident that this was going to be a good talk, just in case. So I'm glad I didn't see any other of you flipping through your books. So at this. For any of you that want any of the resources, this is the link to my Dropbox folder. It'll be there for 30 days. It's got the presentation. There's about 50 or 60 in different folders for all the different indications. Feel free to look through that if you want. And then if anyone has any questions or any comments about their personal experiences.
Natalie, in the pediatric population, probably our primary use is with the coagulation disorder kids. What you're seeing is for minor bleeds. Many of the protocols now are using TXA rather than these half dose or a third dose or that coagulation products, as you can imagine, because of the cost. Mm-hmm. So I think that's what I see as our primary use anymore.
Okay, great. Sorry, I don't have my glasses on, so people are just going to have to... I think that's Laura.
Yeah. I just had a question just about use in the gynae patients. I do use it, but I must admit every time I prescribe it, I kind of feel like I don't really know what I'm doing. People are asking me, so when's my bleeding going to stop? And I'm like, I don't know. And also, am I supposed to be, telling them about potential risks associated with prescribing that drug?
So in terms of when it's going to stop,
that's the most common thing.
Yeah, and unfortunately this doesn't help. I think that you can tell them that there's good evidence that this is going to reduce your bleeding from somewhere between 35 to 55%. Sort of say most of the trials looked over 3 cycles, patients so kind of over the course of 3 months. Not necessarily immediately. So I think you should warn them not to expect immediate results, even though they are only taking it for the duration of their bleeding. I didn't come across any numbers, and I think the problem is that the studies are underpowered to detect numbers, but overall, I'll try and find the exact reference for you, but in one of the review papers, it was basically saying that for the gynae indications, there's been something like 75,000 patients that have taken part in these studies. Now, various doses and various regimes, but that overall, looking at those 75,000 patients, the risks of thromboembolism seem to be consistent with just the baseline risk in the population.
What's safe for the pill or this? And I'm still not entirely sure I know the answer to that question.
Yeah, and unfortunately, I'm not sure I can answer that for you either.
Kind of their goal too, right?
Yeah.
Someone that doesn't mind kind of having birth control, basically,
yeah.
versus the person that still wants to be reproductively active. Obviously, this offers you a different option. Yeah. My understanding with gynecology, when I've prescribed it before as well, one consultant was a big fan of, you started off as 1 gram TID, and usually within 24 to 48 hours, you can stop. And he just tells you to stop when the bleeding stops, as opposed to continuing it and maintaining it. But it's a way just to shorten natural cyclical bleeding.
Come in who are just having this period that won't stop, right? That's the most we'll see. And so in that population, you don't really know, maybe this might even be the first time they've ever had this happen to them. And a lot of people, once you start talking about hormones, a lot of people are like, I don't want to be put on hormones, particularly perimenopausal So I was never really clear on, A, is this likely going to stop the bleeding? When I've talked to gynae, they make it sound like it's going to make it stop, and I'm not sure about that. And also, is it actually a safer option for that population than birth control pill? I don't know.
I think there's good evidence for safety, or there at least in large number of patients there's not good evidence for harm compared to the pill. And in terms of that, I mean, I think you're right. The bigger problem would be if this is a first episode, what is potentially underlying it? But while they're waiting for their gynae follow-up, I think it would be very reasonable to, do sort of a 5-day course and say, I hope and I think that this will at least help you in this episode over the next few days. Obviously, you still need follow-up, but at least it's something that we can do that will hopefully help them in the meantime. John?
I missed something when you were talking about trauma. I thought I heard you say if there's going to be a delay in transferring a patient from a smaller center, you may not want to give TXA. Did I hear you say that?
Yeah, sorry. So if you're in the smaller center, we want you to give TXA. In terms of if a patient would be arriving to LHSC, like if they've been hanging out somewhere and then Orange brings them out and you're looking at your watch and saying, well, it's been 5 hours since their injury, should I consider TXA now? I would say no. Sorry.
We should be promoting this in the smaller centers.
Yes,
to
and
administer
pre-hospital as well. So it's Orange is giving it now at the direction of the transferring physician. They're giving it pre-hospitally because it is time sensitive, and early does seem to be better.
Through you to RAM, are the TTLs routinely recommending it for patients that you're getting from the periphery?
Yeah, like if I work in periphery, so I'll give it myself when I'm working, but I would recommend if I was on the phone that if they have it available to give it, if they've received a patient within that time period. And like I said, it's part of the, if you order trauma transfusion protocol here, like you say activate it will actually come up with the
Fort Campbell's or Listowel or wherever. Are you recommending it?
If you have it.
Just when you were talking with the TCLs and the other people involved in trauma, did they give you an impression on how often we're doing the second dose of TXA? Like it seems like the first dose is being picked up. We give the 1 gram bolus, and then there's this 1 gram over 8 hours, this nebulous second dose. And from sort of my experience with a lot of the trauma people, it doesn't
It's forgotten
that often.
Oh.
Yeah.
I don't know. That's a great question. I didn't ask that specifically, but you're right. I could see how, especially if a patient's really sick and access and lines are at a premium compared to for other things, that might be forgotten. So I'm not sure.
I think it's forgotten.
Yeah.
I just haven't seen it.
I think it will come up with further, if you keep going with the trauma transfusion protocol, it's supposed to come up with the rest of it. But if you're giving TXA and you've activated the trauma transfusion protocol, there's other competing priorities, I think, in your mind, and you may forget.
Yeah.
Unless it's protocolized.
Well, and it may be helpful, they've only done this for the TBI study, but further studies may show us, like, is it the bolus that's helpful? Is it the infusion? Which one? Is it the combo?
You know how long you wait between giving the bolus and starting the infusion? Like, is it bolus finishes, start infusion, or is it an hour later?
They didn't specify. It was sort of over the next 8 hours. So my understanding of that was that you run the bolus and then ideally the infusion would start. I didn't read any data from any studies on practically how that played out. Anything else? All right. Thanks everyone for your attention.